Good afternoon, everyone, and we thank you and welcome you to actually the first of our academic year this year. It's a little late in the summer to be starting, but we're glad to have you with us and glad that everyone from around the state could join us. Today we're going to be talking about genetics and care for children with congenital heart defects. Our primary presenter is Dr. John W. Belmont. Dr. Belmont holds an MD and a PhD. He is a native of San Antonio, Texas. He obtained his medical school degree here at Baylor College of Medicine. He had his residency at Children's Hospital Boston and at Baylor College of Medicine. And his specialist interest, his research interests, are cardiovascular genetics. His clinical interests include birth defects and congenital developmental anomalies, cardiovascular genetics with special interest in cardiovascular malformations, and connective tissue disorders and primary immune deficiencies. Also on the program this afternoon is Susan Fernbach. Susan Fernbach is a native of Houston, Texas. She attended the University of Texas in Austin and Texas Women's University, where she obtained her BSN in nursing. She has been a genetic nurse for more than 30 years. She is currently an instructor in the Department of Molecular and Human Genetics at Baylor College of Medicine, and she's the Director of Genetic Outreach at Texas Children's Hospital and Baylor College of Medicine. And of special note, she is also the director of a program called Evenings with Genetics, a community seminar series that has expanded to statewide programs. And this, ladies and gentlemen, is a program of that nature. And with that said, we will hand it off to our first presenter, Dr. John Belmont. Dr. Belmont?
Well, thank you very much for that introduction, and I'm very, very pleased to be part of this program, and especially pleased to know that this is being broadcast in so many different places in the state. So what I'm going to do is talk a little bit about some of the genetic causes of congenital heart defects as we know them so far, and give you just a general idea of the state of knowledge, how we evaluate children with these conditions in the genetics clinic, and how we want to work with the cardiologists and cardiovascular surgeons to improve the care of children with congenital heart defects. So I'm going to start with just a little bit of a refresher on genetics, because a lot of this information feels pretty foreign. You might have heard a little bit about it in high school and in nursing school, but now be pretty far away. And I'm going to talk about it in a way that is fairly low key, because this is the way I like to describe our work to the patients and families that we see. So the genetic material is like a big encyclopedia. The encyclopedia contains the genetic information, the genes, and they're like a parts list for the assembly of the body, both the development and its maintenance. The genetic material is arranged in volumes like the encyclopedia, and those are the chromosomes. And we get an entire set of chromosomes from each parent, so everything is in 2 copies. So just following along this metaphor of the genetic book, you open the book and there are paragraphs, and that's the way the genetic material is also organized. People, human beings, have about 21,000 genes in the whole genetic book, and these genes are important for every single function that there is in the body. So far, from both our knowledge of human beings and various animal models, there are about 300 genes that are known to play a role in normal heart development. So it's not surprising that some of the genetic disorders that have been identified so far involve some of these genes that play a role in normal heart development. So drilling down further into our this metaphor of the genetic book, the paragraphs are made of words. The words are spelled with letters. The genetic material is the DNA, and there are 4 bases in the DNA. These are the letters that we decode when we're evaluating a gene. And instead of the 26 letters of the alphabet, we have A, C, G, and T. So it's simpler in principle, but presents a lot of challenges to us when we try to read a gene for the purposes of making a genetic diagnosis. So if we think about, well, what are the causes of heart defects in children? There are missing or extra books in the encyclopedia. This would be the chromosome anomalies. So a whole volume is disturbed or out of balance. There could be paragraphs missing or duplicated, and this constitutes a new group of conditions that we've just been learning about over the last 15 or 20 years, and we call these the genomic disorders, and I'll give you one example of that. One can have misspellings in single words. These are the single gene disorders. And then we've got a lot of patients where things seem to be a lot more complicated than just these more simple mechanisms, and those are the multifactorial, and those play a very large role in the origin of heart defects. So chromosome disorders, let me just give you one example. This is the typical chromosome display. This is called a karyotype, and what you can see from the karyotype is that the chromosomes are of different lengths. The chromosome number 1 is the longest. It has this characteristic pattern of stripes. There's 2 chromosome 1s, one from mother, one from father, and the same for each of the other chromosomes, ordered based on their size, 1 through 22. So 22 pairs of chromosomes, one each from mother and father. And then the 23rd pair of chromosomes are the sex chromosomes. So this would be the karyotype of a female, two X chromosomes. A male would have 1 X chromosome and a Y chromosome. So we do see babies born with chromosome abnormalities, and Down syndrome is the most common of the chromosome abnormalities. Here, in the most common form of Down syndrome, we go down, number 1, 2, 3, etc. are in pairs, but the chromosome number 21, instead of having just 2, we have 3. So we write that 47XY. So here's the Y chromosome and an X. So this is a male with the extra chromosome 21, or trisomy 21. And about half of children with trisomy 21 have some kind of a heart defect. The most classic one is in the group of the so-called atrioventricular septal defects, or AVSD. Here's a picture of a child with Down syndrome. Any of you who've been involved in pediatric nursing would have seen many children with this. In fact, there are many people in the community with Down syndrome. And this is the atrioventricular canal type of defect. So just to kind of orient you, because I'm going to show a couple of more pictures of slides. Here's the right atrium where the blue blood comes in from the body, and it gets passed into the right ventricle and then pumped out through the pulmonary arteries into the lungs, where the blood picks up the oxygen, comes back into the left side of the heart through these pulmonary veins into the left atrium, and then goes into the left ventricle, where it gets pumped out in this big tube, the aorta, where the oxygenated blood goes into the body. So in the atrioventricular canal defects, there's connections that shouldn't be there between both the right ventricle and the left ventricle. So blood flowing from the right, mixing in from the left and mixing into the right in a way that it shouldn't, and the same at the level of the atria. So this abnormal mixing of blood causing the blood to over-circulate. All right, so that was the most characteristic heart defect in Down syndrome. Here's an example of a genomic disorder, which is the most common one that causes a heart defect, and this is DiGeorge syndrome. It has various other names like velocardiofacial syndrome, but that isn't so important. Is that there is also a kind of a characteristic facial appearance to children with DiGeorge syndrome. And other kinds of birth defects. They may have a cleft palate. They can have, as you can see here, ear abnormalities and inner ear abnormalities. A child with complete DiGeorge syndrome may also have an absence of thymus, and so have an immune problem. The type of heart defects that are characteristic of DiGeorge syndrome are are what are called conotruncal defects, and the most well-known of those is the so-called tetralogy of Fallot. All right, so in DiGeorge syndrome, if we looked at the chromosome pattern, we wouldn't see any abnormality at all. But if we take a very close look at chromosome 22, we will see an abnormality, but we have to use a different kind of technology. This is called a microarray. So in a microarray, what we see here is this. Let's look at this little cloud here of blue dots. Each of these corresponds to a little genetic assay that's been fabricated onto what's called a gene chip. And so you look along here and you see everything is normal, but then there's a dip here indicating that there's an imbalance of the genetic material. So in the classic DiGeorge syndrome, there is a deletion here in this part of chromosome 22. One of the chromosome 22s is normal, the other one has this deletion in it. How about misspellings in single genes? Well, for that kind of analysis, we use what's called DNA sequencing. These are robots that can read the genetic material, read that genetic code, the pattern of letters, A, C, G, T. So here's an example of that where you can see the C, the A, a mixed position, and then the T and the G. So this could be a mutation here. There are various kinds of gene mutations. And here's a good way to think about how the mutations can affect the spellings of words in the genetic code. So here's the normal sentence, put the puppy in the box. If we have a deletion, put the in the box. Duplications, put the puppy in the box. Misspellings, put the poppy in the box. All these kinds of things can occur at the level of the genetic material, and they will disrupt the function of the gene. Here's an example of a common syndrome that has where these children have heart defects, conotruncal heart defects, just like in the 22q11 deletion syndrome. These children with CHARGE syndrome also have characteristic facial features, and they have a lot of other health problems and other associated malformations. This disorder is caused by mutations in a gene called CHD7. And I'll talk a little bit about what it means that these are new mutations, that is, mutations that are not in the parents, but just happen brand new in the child that has this condition. Our final category of inheritance or mechanisms, genetic mechanisms, is multifactorial. So this is also called complex inheritance. So if we start adding up all the different known causes of heart defects, chromosome abnormalities are about 10 to 12%, genomic disorders, and especially that 22q11 deletion syndrome, about another 10%, sometimes as high as 15%, depending on how you define the patient groups. Single gene disorders, much less common, we think, and then the vast majority of patients, around 75%, that are either multifactorial or that have some of these single gene disorders that we have not yet been able to discover. Now, relatives of children with heart defects can have anomalies of the heart. So parents and siblings of children with hypoplastic left heart syndrome, for instance, should get an echocardiogram, and they have a 5 times increased risk of having an anomaly of the aortic valve, especially the bicuspid aortic valve. And there are other so-called minor anomalies of the heart that have been detected in nearly 20% of the close relatives. So this is telling us that that complex inheritance is happening in the family. There might be other family members that have a minor problem with their heart, and it's just shown up as a more severe defect in the child who has something like hypoplastic left heart or coarctation of the aorta. So are people with congenital heart defects more likely to have children with congenital heart defects? This would be a sign that there is some kind of genetic factor in play, and the answer to that is yes. Adults who have CHD are more likely to have children with CHD, and an infant born to a family without a history of CHD, that family has about a 1% chance of having a child with CHD, but the risk increases about threefold for a family that in which the mother, father, or brother or sisters have CHD. Environmental factors can also contribute to heart defects. We know of some environmental factors, especially pre-existing maternal diabetes, maternal obesity, a rare genetic condition called phenylketonuria, or PKU, that we screen for in Texas, and possibly respiratory virus infections like influenza or anything else that might cause a mother to have a fever. One of the most important environmental exposures I'd like to emphasize is that's been consistently detected in epidemiologic studies is maternal smoking, certainly a preventable risk factor. Here are some other teratogens. Teratogens mean outside agents that can cause birth defects, and all of these kinds of things can contribute to heart defects, many of them interacting with the underlying genes, so that for instance, exposure to a medication or exposure to alcohol by itself may not cause a heart defect in every single child, but it does drastically increase the risk and suggests that it's interacting with some genetic susceptibility. So a child with congenital heart defects, and especially if they have other kind of birth defects, will often be referred to the genetics clinic. So let's talk a little bit about what would happen in a genetics clinic evaluation and the role of nursing care, and also what the parents can expect, so you can help them understand that. So the visit to the geneticist is a lot like a lot like a visit to any of the pediatric specialists. We take a history and with a special focus on the pregnancy history, and a much more detailed approach to the family history, which I'll go into in just a minute here. We're going to do a physical examination, but it's going to be a little different than most pediatricians do, because we'll look at some details of how the craniofacial features have developed. We'll make some special measurements that are shown here in this little diagram. We'll look at some other kinds of parts of the physical examination, like the fingers and toes. These just help us a lot in understanding whether or not there's been some kind of problem in early development. We're likely to order some specialized genetic testing. We're going to possibly do some additional imaging if that kind of thing hasn't been done already, because we want to know, in addition to the heart, are other organs like the kidneys and brain especially affected by a syndrome. So the genetics family history is very different or more detailed than what the typical pediatrician will do, or in the other specialists. So we'll take a 3-generation pedigree, and in our pedigree, the males are going to be represented by boxes and females by circles. So here's our patient, a male, and he is the proband, so we put a little arrow there. And we'll color the box so that there's red for the tetralogy of flow and blue for a cleft palate. Now we'll extend a little bit. So everybody's got 2 parents, a mom and a dad. So there's the parents. And it turns out that mom has a brother, full brother, and that the brother his wife is pregnant. So this is a way to represent this pedigree. We'll come back to this in just a moment. But one last thing to say about this pedigree is that after going through the interview, we find out that mom had a cleft palate that was repaired, and that's really very important for understanding how this might relate to the problems in her son. Now here's an example of a positive family history. We have our proband here who came to the clinic with a ventricular septal defect, but when we drew our pedigree, we learned that the mom also had a VSD, or ventricular septal defect. Her brother didn't have a heart defect at all that we know of, but his daughter had an atrial septal defect. So we are concerned that there could be a gene in the family that's responsible for causing both the ventricular septal defect and the atrial septal defect. And how might that work? Well, this could be an example of dominant inheritance. So in dominant inheritance, we're representing the individual genes. The little d is the normal type without a misspelling. The big D is the copy of the gene with the misspelling, and now we can track this. So the big D has been inherited from mom to her son. He has the VSD. The grandfather did not have any kind of heart defect that we know of, passed through without showing itself in the maternal uncle here, mom's brother, but then shows up again in the cousin, the first cousin, the little girl with the atrial septal defect. So this gives an example of dominant inheritance, but also variable expression, because these two had VSD, she had an ASD, and also incomplete penetrance because these two people did not get a heart defect at all. Here's an example where there's an affected sibling. This brother had hypoplastic left heart. The sister had transposition of the great arteries with intestinal malrotation. Now, when we see affected siblings and the parents are unaffected, we might consider the possibility that there could be another kind of inheritance that's called autosomal recessive inheritance. In recessive inheritance, we represent the gene with the misspelling here by the little r, and you can see both of the siblings have 2 copies of the little r, so they both got 2 mutations, and that causes the severe heart malformations. The parents are each carrying 1 little r, so they're carriers. They are protected. They don't get a heart defect because they've got the big R, the non-mutated copy that carries out the gene function, and so the carriers are not affected in recessive inheritance. This would also be a very typical kind of pedigree to find if we take a family history in children with a congenital heart defect. So here's our child with the tetralogy of Fallot, cleft lip and palate, and undescended testes. Neither of the parents have either of these. This could be a syndrome that we could diagnose. The gene might be known or not known. But the most likely pattern of inheritance is new mutation. What we mean by new mutation is that a new genetic change has taken place, either one of those genomic disorders or a misspelling in one gene, and it's caused all these birth defects, but neither of the parents have the mutation. It's something brand new that's happened only in this one child. So just to review our patterns of inheritance, we have dominant inheritance, recessive inheritance, and de novo dominant inheritance. And these are the major patterns that we might see in a child with a heart defect. Well, what are the clinical benefits of going to visit the geneticist and working this out and doing genetic testing that might identify a specific gene misspelling? The 22q11 deletion syndrome it provides a nice example, as does Down syndrome. We can provide anticipatory monitoring. For instance, in 22q11, we might not previously have obtained a kidney ultrasound, but now we know that we need to do it because nearly 20% of children with this condition have a kidney developmental abnormality. Children with Down syndrome need to have annual thyroid screening, so this is something that knowing the genetic abnormality tells us that we need to take care of the child in a different way. Children with 22q11 deletion also need to have speech therapy, so we know that we don't delay in introducing that. I gave the example of parents and brothers and sisters of a child with hypoplastic left heart. They need to have echocardiography because they have a high risk of having a heart problem themselves. And we can also tell the parents specific information about recurrence risk. For example, if it was a recessive inheritance, then it would be a 25% recurrence risk. But if it was de novo dominant inheritance, then the recurrence risk would be very, very low. Now I'm going to just take a couple minutes to talk about our current approach to diagnostic testing. And if any of your patients are referred to a genetics clinic, they're likely to have one or both of these kinds of genetic tests. The first to give emphasis to is the microarray. And what a microarray is looking for is an imbalance in the genetic material, like those genomic disorders that I discussed previously. This is a relatively new technology, and it's revolutionized how we evaluate children in the genetics clinic. It's been available for nearly a decade now. We've also been doing DNA sequencing for a while, but we have a brand new technology that I want to tell you a little bit about, where we can essentially read all of the genetic material all at once. So there are many different ways to do a chromosome microarray analysis. It's now widely available. Even all of the county systems have contracts to allow microarray testing in children with birth defects. The type of technology that we use here at Baylor College of Medicine and Texas Children's Hospital has been developed here. We're one of the largest reference laboratories in the country, and the laboratory has probably done in excess of 60,000 tests. So that's really helped us to be able to interpret the results when we see very uncommon kinds of problems. But even today, we find abnormalities that we've never seen before, even after testing that many children. I showed this slide before, but it just takes us back to this giving emphasis that this is really a new era in chromosome analysis. Previously, we would only be able to look at pictures of the chromosomes taken under a microscope, but now we have this very high resolution way of looking for very small deletions, very tiny deletions or duplications in the genetic material. And so far we know of about 40 to 45 genomic disorders that can cause a heart defect, with that 22q11 being more than half of the ones that accounting for more than half of the patients that we actually find a disorder. So there are advantages of doing this microarray testing. More causes of heart defects are found. We can detect unsuspected genetic defects in the parents. Sometimes parents don't know that they have the 22q11. In fact, I'm seeing a patient a little later this evening that has exactly that situation. We can look for associated medical problems in children and anticipate any problems with delays in development if we find one of these conditions. So it may not be just heart defect by itself. Now we have a new technology that's revolutionizing the way that we evaluate patients. It's called next generation DNA sequencing, and goes by another name which you may hear doctors talking about, whole exome sequencing, or WES. And just a kind of a general idea of what this is, that the genetic material, as I said, is organized in paragraphs, but those paragraphs that are actually coding for the genes only make up about 1.5% of the DNA. The rest of the DNA is more regulatory. So we have a way of capturing that 1.5% and just focusing on that and reading off all of it at once. So this turns out, even though it's an extremely complicated thing to do, it turns out it's much less expensive and more thorough to evaluate someone where we know that there might be a whole lot of genes that could be involved. Let me put that in perspective. So for congenital heart defects, we already know of more than 150 genes that may cause a heart defect. So when we're dealing with that number of genes, this turns out to be an extremely cost-effective way to just go through all of those 150 genes all at once. Well, I'm not going to go through this in any detail. I just want to just show you that the way this is done is amazing, really. It's just this little glass slide with these stripes on it, but on this glass slide, if you looked under a microscope, you would see these essentially billions, 1.5 billion tiny little features represented here by these colored dots. And these colored dots are imaged with a special microscope. And so here you get the idea. You just with the microscope focusing on just one dot out of this whole big cloud. It's green, that's a T. It's blue, that's a G. It's red, that's a C. Goes back to green, that's a T, etc. So the computer and the camera does this at all these billions of little dots. Then we use big computers to assemble that information, and basically we can read off all the genes at once by doing that. This is some examples of some cases that we've seen recently in our program here at Baylor, and I selected these because every one of these disorders is accompanied by a particular kind of heart or blood vessel defect, and it would be very hard for us most of the time to recognize these conditions in a newborn, but if we apply this kind of technology, we can rapidly come to a diagnosis and not have any delay of figuring out what is the cause of the condition in the child. Well, the families may ask some questions after all this genetic evaluation, and these are just general kinds of things. What can I do to minimize chance that my child will have a heart defect? And so the first thing is learn about nutrition, physical activity, and lifestyle effects on risk for heart defects. And women of childbearing age should take multivitamins, including folic acid, on a daily basis. Avoid cigarette smoking and alcohol drinking if you're thinking of having children, and even if you're not, to even avoid cigarette smoking. And avoid exposures to organic solvents, another known risk factor for heart defects. What can I do to minimize the chance that my child will have a heart defect? Women who smoke should stop smoking, obtain preconception and prenatal care, including testing for diabetes and past rubella exposure. Discuss medication use during the pregnancy with their physicians, because there are medications that will increase the risk of having heart defect, and avoid ill contacts in the first trimester, especially those with febrile illnesses. For families who have a child with a congenital heart defect, they should know their family history, update that family history as they grow so they can give accurate information to their doctors and nurses, and get up-to-date information for each pregnancy, because as we go, we're learning more and more about what causes heart defects. And so families should not just rely on information that's even 2 to 5 years old, because there's a lot of new information, and especially every few months there's more genes identified that can cause a heart defect. So my final exhortation is to be an advocate for research. We're carrying out research programs here at Texas Children's Hospital to try to find the causes of heart defects. We're doing that in collaboration with the Human Genome Sequencing Center at Baylor College of Medicine and the staff at Texas Children's Hospital. And so help us and let families know that we are here to try to improve care and knowledge about these defects. So I am going to stop, and I'm going to give the podium, as it were, over to Susan.
Oh, wonderful. Thank you very much. And it really is, we are thrilled to see you all. We know that there are nurses, social workers, ECI providers in the audience, and thank you very much for taking your afternoon and spending with us, because I think it's a really important topic. And this funding to offer this is coming from the Texas Department of State Health Services, and obviously they feel that it's really important to reach out to you all and provide this information. So what I'm going to talk about is just some very practical information on reaching families and how best to reach families in your practice. So how can you help? And we don't expect you to be a genetics expert, and we're trying to give you tools to help you when you're seeing families, and helping you identify at-risk families, refer them for a genetic evaluation, support the families, and offer resources. So I'm just going to talk about those things very briefly, and then we can open it up for questions. Some of the red flags in identifying families, and these are just a few, but is there more than one organ or system involved? So if you're seeing a child and you're trying to figure out what are the features with this child, and it's a little bit of a mystery to try and pull all of this together, certainly a genetic evaluation can help with figuring out that puzzle. Are there similar issues in other family members? Does a child have dysmorphic or abnormal features, or is there a characteristic appearance in other family members? So those are kind of things that can help you get started if there is a family that you're uncertain about. Referral. The Texas Department of State Health Services has a great website that lists all of the providers around the state. There are some areas of our state that have a lot of geneticists. Houston does. We're very fortunate here. There are a lot in Dallas. There are now providers, San Antonio, Austin, McAllen, Lubbock. But there are many places in Amarillo. There are providers that are coming once a month. There are many other sites where there really aren't providers. And so this will give you a listing of where you can refer a family and see who is closest. The American College of Medical Genetics also has on their website a way to find genetic services around the country. So if there are other family members that then decided that they wanted to have a genetic evaluation, it would definitely be possible by going through the American College website to find services. Dr. Belmont talked about the family visit, but I wanted to just add that oftentimes families want to, before they come in, kind of assemble the information, and we definitely encourage that so that they can get together the family tree or the pedigree And I will tell you that some families have said, a pedigree, I can't believe you're using that word. Isn't that for animals? And we said, no, a pedigree is really for humans as well, and for mammals. So it is a term that's used. Including this website here, My Family Health Portrait, that can be done. Families can link onto that if they have a computer, or if they go to a library for a computer. They can record their family health history. It may take 20 to 30 minutes initially. They can save it if they have their own personal computer, or they can print it and take it to their care provider, and then they could update it later on. So it's really an incredible health tool. This is put out by the Surgeon General, and every year a reminder goes out when people get together for Thanksgiving to maybe talk about if there have been any new health updates for family members. So this is the actual website. This is in English, Spanish, Portuguese, and Italian. So it is available in a variety of languages, and it's quite easy to use. So I recommend that all of you try it out yourselves as well. So the genetic evaluation, the first visit actually can last quite a bit of time, maybe an hour and a half. So you can prepare families for that they are going to be there for a little bit as all of the information, the medical records, the physical exam is done, the family health history is obtained, and then any recommendations for additional testing or recommendations about the diagnosis that's determined. And follow-up is a really essential part of this. So I would help families understand that, because we do want to see families back to review the results, to discuss the diagnosis if it's known, and form the plan of care. We don't want to lose families to follow-up, because if we don't understand what the diagnosis is and the testing doesn't indicate it, it's possible that in the future either the child's features change as they get older, or that the testing has changed and it would be possible to make an evaluation. So follow-up is essential. When the diagnosis is made, as Dr. Belmont said, we also discuss all of these other things, the recurrence risk, the chance to have additional children with the condition, the reproductive options are discussed. We may discuss testing other family members, and we provide support and resource information. We also, I think all of us can support families when they're considering a genetic evaluation and testing. So you are there and able to answer their questions in a way that if you see families on an ongoing basis, you have their trust and can really sit down and let them know what this is all about and what it entails. Families who've been on the long journey, the diagnostic odyssey, to try and figure out what their child has, may be relieved when the diagnosis is finally made. And you can help families connect with other families or support groups that have a child with a similar condition. And that's really changed dramatically from when I started as a nurse in genetics, because obviously I started, well, before the internet. And so now there are just so many other ways of connecting families, not just by phone call, but through all of the groups that are available locally, nationally, and internationally. There is a listing of core competencies that's now available for nursing and also available for all health professionals. So I would encourage you to look at these links. It gives very helpful information about where everyone should be as far as their understanding of genetics and how they can help families in their practice. There are web sources, resources that are very helpful. That these are ones that are not only great for professionals, but they're also really good for families. So if you have a few minutes, we've given you a web resource handout that is a front-back handout that has a lot of the web resources that are accurate, they're up-to-date, and they're trusted. And so I think that when families are looking for information, it's really helpful to refer them to those type of web resources. Certainly for the congenital heart defects, there's the American Heart Association. There are some support groups that have now gone national, the Congenital Heart Information Network and It's My Heart. So those are all really great as well. So we would really like to thank you all for participating today, and for the Texas Department of State Health Services, and for the collaboration with the TCH Center for Telehealth. I'd like to open this up for questions now, and any questions that you all have for Dr. Belmont or myself, we are very happy to answer them.